Hello everyone, this is Dr. Sanket Pisat, and today on the Endogyne training group we are going to discuss yet another important topic related to gyne endoscopy. In fact, we have now started another channel or WhatsApp group for members to be able to post their views freely as compared to the previous group, which was a broadcast only group. So those of you who are interested in joining, please visit the website endogynetraining.com, where you will find the link to join both the groups, and you can also take part in the daily discussion. So what the question that we were discussing this weekend was cervical stenosis and difficult entry into the uterine cavity, and a lot of members have posted their queries and their difficulties and also their experiences across different countries and how they are managing it in their own practice. So overall, it has been a very enriching experience for everyone. I am now going to give my views on the topic. Again, like those of you who have already been on the group know that this is our standard disclaimer that no one knows everything. And these are my personal opinions. They may be different from published evidence or conventional teaching. But if you have a difference of opinion, we'd love to hear from you, provided that it is backed by some sort of logic. So please leave your views in the comment section below the video or on the WhatsApp group if you're already there, and we can further discuss the matter as it comes. So the question that someone had posted was that they had a difficult entry in hysteroscopy and this resulted in a probable perforation or a suspected perforation, and then that got the ball rolling as to what should be the different ways of managing these problems in hysteroscopy. So let's see the options that have been put up by various members in the group, and let's tackle them one by one. So the first option or the first modality which had been suggested was the vaginoscopy hysteroscopy entry. Now, as far as my practice is concerned, and I say this with regards to my personal experience only, we have been doing vaginoscopy hysteroscopy entry and entry without holding the cervix in a majority of cases over the past few years, and it has been tremendously helpful because you are able to negotiate into the uterine cavity without applying any excessive pressure or excessive force on the cervix, and then you are really able to have the saline open up the way and lead you into the uterine cavity rather than forcing your way through. So it was first dilate and then see. This was what used to be done before. That means we used to dilate the cervix first and then thrust the hysteroscope inside and then see what is in the uterine cavity. But now the dictum has become see and enter. So we always try to enter the uterine cavity under vision, never by just plain dilatation. There is still a place for dilatation also, but as far as possible you must try and enter the uterine cavity under vision, and most of the times these issues related to difficult entry will get solved by this one method alone. So I think that clears the thing on vaginoscopy hysteroscopy entry. Now we come to the second question about holding versus not holding the cervix. Now the thing is, if you are doing an office hysteroscopy, so I think someone has also mentioned about office hysteroscopy, so we will take both of these pointers together. Now when we talk about office hysteroscopy, actually as it is practiced correctly in the Western world and particularly in Europe, Professor Stefano Bertocchi, I believe, started office hysteroscopy, and the idea was to do hysteroscopy without anesthesia. And when we say without anesthesia, we mean without any form of anesthesia. So I had the good fortune of studying in Belgium for a while in the same center where Professor Bertocchi and Professor Bruno van Arendal, my teacher, used to practice. And you are not technically even allowed to touch the patient's labia. The patient has to be that comfortable, let alone inserting a speculum or holding the cervix with an Alice. So that's office hysteroscopy for you. But even if you are not doing office hysteroscopy, please try to understand, even if you are not doing office hysteroscopy, still learning the technique of office hysteroscopy will go a long way, because using this technique you are able to naturally, when you are doing hysteroscopy without anesthesia, there is no question of doing any dilatation. And when you learn this technique and master this technique, you can do the same technique under anesthesia as well. So in office hysteroscopy, there is no anesthesia, but even if you are doing it under anesthesia, the entry, if you have learned the correct technique, will be safer, easier, and less traumatic for your patient. So learn the correct technique of entering using the see and enter approach rather than the dilate and enter approach. Now the question is, we were at point number 2, which is holding versus not holding the cervix. So now the question is, if the patient is already under anesthesia, then what is the harm in holding the cervix? So technically, no, there is no harm in holding the cervix, although it may not be necessary if you are having a 2.9 or a 1.9 office hysteroscope. It may not be necessary to hold the cervix, but yes, under anesthesia you can hold the cervix with a speculum or with a valsillum or an Alice forceps or whatever you wish. I would recommend holding the cervix in certain circumstances. So typically one finds that whenever one has a difficult entry in hysteroscopy, most of the times one can expect that the uterus is going to be acutely antiverted. So at least in my practice, or from what I understand, if you have a difficult entry, then 95% of the times we are talking about an acutely antiverted uterus. Very rarely will you expect a difficult entry in a retroverted uterus, and hence the simple act of holding the cervix with a valsillum or an Alice forceps and giving traction to the anterior lip of the cervix, this alone will straighten the cervical canal in a vast majority of cases and enable you to be able to go inside easily. Remember, of course, that the patient is under anesthesia. We are not talking of a patient who is not anesthetized. But if the patient is under anesthesia, then do not completely disregard the concept of holding the cervix, because the simple act of holding the cervix alone may be able to let you insert the hysteroscope inside in a majority of cases. So like I explained, if this is the uterine cavity in a normal lady and you are able to enter the uterus like this, but in a acutely antiverted uterus you are going to have a cavity which is something like this, and therefore you are going to find it difficult to enter. Holding the cervical lip at the anterior part, that means, so if I suppose hold it with an Alice over here and pull it down, this is going to straighten the axis which was bent, and this uterus is now going to somewhat change, maybe not into an entirely normal aligned uterus, but it will significantly change into a uterus which has got a more straight axis of entry, and therefore just by pulling the anterior or holding the anterior cervix, one may be able to get inside very easily. Then came the question of hypertrophied cervical crypt. So when and how do you identify a hypertrophied cervical crypt? So if this is the cervix entirely, you know that there are folds which are seen, and you know that these folds guide you the correct path of entering into the uterine cavity. This I have shown in my videos also previously. These are there already on the YouTube channel. So if one of these crypts, let's say, is hypertrophied, most of the times one finds that the crypt at 12 o'clock is hypertrophied, or it could be another one also. This hypertrophied crypt grows over and blocks the entry into the or blocks the internal os. So one may imagine that the internal os is somewhere over here behind this entire thing, but you are not able to see it because of the hypertrophied cervical crypt. In this case, I would strongly recommend that it is absolutely essential to resect this cervical crypt. Cutting this, in my opinion, cutting it with the scissor will not help, because one, it will bleed, and moving the scissor inside the cervical canal is a pretty difficult proposition because there is very limited space inside the cervical canal. So it would bleed a lot, it would not be a complete job, and with the resectoscope it literally takes less than 1 or 2 minutes to shave off one crypt and make the entire tunnel into the internal os easier. What's more, you will find that your subsequent attempts at IUI or embryo transfer become so much easier, you will wonder why you didn't do it in the first place. So in my opinion, cutting with the scissor will not be a very good idea. Trying to force the dilator through will not be a good idea. If you can see that there is an obviously hypertrophied cervical crypt, at least I would like to resect it and then move forward. There is really no option to buying a resectoscope. You will, if you want to advance in hysteroscopy or laparoscopy, equipment is something you will have to have, because endoscopy is 50% equipment and 50% surgeon skill. So there is really is no choice in the matter. You will have to upgrade on that front. Then we come to Misoprostol. So this I am going to take last because it's full of controversy. Let's take false passage prevention and management. So in order to prevent a false passage, like I said, we go back to entry with the vaginoscopy hysteroscopy technique. And if you do not dilate, or if you avoid the use of dilators, in many of the cases you can avoid this false passage completely. Now the question is, when you are suspecting a false passage, or you have got a patient with a history of false passage, or generally you have got a patient in whom there has been a difficult cervical entry, one must ask the question why. Okay, if the answer is just antiversion of the uterus or acute antiversion of the uterus, then this is a fairly easy thing to manage. If it is hypertrophied cervical crypt, then also I would say it is an easy thing to manage. What is difficult to manage is a difficult entry or non-achievable entry into the uterus because of adhesions. And because of adhesions, you may have tremendous difficulty and you may end up going into a false passage no matter what you do. So there are some techniques. I'll try and discuss these in subsequent videos. But in cases of patients in whom there are known synechia, be careful that you may have a false passage at any point of time. And therefore, at least in these patients, I get several referrals where people have not been able to enter the uterine cavity previously, and in these patients I always take a consent for laparoscopy. Although I end up not performing laparoscopy in a majority of cases, I take consent for laparoscopy, because who knows when a perforation will occur, and it is good if you have spoken to the patient about this before rather than doing this decision on table. So then we come to, so like I said, false passage prevention and management. And I think now is the time to discuss about how to prime the cervix. So there are several people who are in favor of Misoprostol, and many people who are against Misoprostol. So in the group you will see that several people have talked about Misoprostol. Then they have talked about a new agent which I have not been aware so far, evening primrose oil. Apparently on the discussions in the group it is used in the Philippines, but I have no knowledge. And then there are other techniques that have been described, like filling up the bladder and using a Foley's catheter. So I will at least I will tell you my take on the topic. My take on the topic is that if you look at most of the recommendations, they say that Misoprostol is to be used only when a difficult entry is anticipated. Okay, so when a difficult entry is anticipated, I'm sorry about the spelling. So anticipated. Only when a difficult entry is anticipated, one must use Misoprostol. And but the question then is, how will you know when you are going to face a difficult entry? If you have a patient with a previous known synechia, then I can understand. You may get a difficult entry. If you have a patient with a previous pelvic tuberculosis, which is quite common in India at least, then you may expect that there are synechia. If you have a patient in whom previously multiple MTPs, so multiple surgical evacuations, we call them medical termination of pregnancy here. So if such a history is there, then okay, these are places where you may expect that there may be a difficult entry, but at least in my practice I find that there are many patients who have none of the above. And on table we find that we are getting a difficult entry. Now what is to be done with these patients? Should we abandon these and keep them at a later date? That would be unfair for the patient and for you as a surgeon as well. So as far as I am concerned, I am giving Misoprostol to all patients. I know this may sound very controversial, and it is up to you to decide what you want to do, but I give Misoprostol to all my patients except those patients who have had at least one vaginal delivery before, because in these patients the os is extremely patulous and the hysteroscope will enter inside without any problem, or those patients who have got a large intracavitary pathology. So if the patient is being posted for surgery for, let's say, a large submucous fibroid type 0, then most of the times, or a large intrauterine polyp, then most of the times one finds that in these patients the os is open, and therefore Misoprostol is not required. But other than that, I do not find any problem in giving Misoprostol. I give it in a dose of 200 milligram vaginally. I know the recommended dose is 400, but I give it 200 milligram vaginally 2 hours prior to the procedure, to the extent that if the patient is a virgin and is unmarried, then we can give it sublingually as well, and it also acts quite well. In my opinion, at least, it does not cause any excessive leakage from the cervix. Most of the times I use a 2.9 mm telescope, and when you use a 2.9, understand that the effective diameter of the 2.9 plus the sheath goes to about 5 millimeter. So there is no excessive leakage from the cervix in my practice, at least, and I find the entry to be very smooth. Again, I do not find any instance of increase in the perforation rate. I at least do not find as increased. I do not find any changes in the cervix like hyperemia or any artifacts in the cervix for that matter. And I find that giving this Misoprostol, so we putting Misoprostol 200 milligram vaginally 2 hours before the procedure gets rid of the stress of not being able to enter inside the uterine cavity at that given time. So this is my point of view. Of course, you can choose to follow whatever suits you in your practice, but I think vaginal Misoprostol at best has some side effects like slight febrile reaction and maybe a little bit of cramping. But the patients are able to have the procedure done in the same sitting. So I am using this particularly for cases where I am doing inpatient hysteroscopy. Yes, if you are doing outpatient hysteroscopy, then I would recommend that instead of using a 2.9, so if you are doing genuine outpatient hysteroscopy without anesthesia, then at least I would recommend, and I find it useful, that instead of using a 2.9, if one switches to a 1.9 mm telescope, the effective diameter reduces from 5 millimeter to 4 millimeter with the sheath, and then you are able to enter the uterine cavity in a majority of cases without Misoprostol, without dilatation. Okay, so if you are using a 1.9, then I agree that you may do away with the Misoprostol completely, but for 2.9, which I use most frequently because it is not as fragile as the 1.9, I would recommend putting Misoprostol inside a patient 2 hours prior to make things easier. So that settles Misoprostol. Now the use of office hysteroscope, I have already said that office hysteroscope is recommended. For those of you who are using a 4 millimeter hysteroscope, I would recommend you to switch to the 2.9 and see the difference for yourself. The difference may not seem to be so much when you have not used it, but believe me, once you use a 2.9, it will be very difficult for you to go back to a 4 millimeter because the ease of insertion inside is remarkable. So there is really no debate on that. We talked about office hysteroscopy. So saline shows the way. There are opinions in the group that saline shows the way, and I agree that saline opens up the cervical canal and helps us to go inside. But every time this may not be possible, and therefore saline will show you the way in case there is no genuine stenosis. Okay. if there is no genuine stenosis, then the saline will open up the way. But if there is a real stenosis with fibrosis of the internal os, then the saline going inside will not be sufficient and you will have to think of something else. My recommended technique would be to dilate under vision. And dilate under vision means, as Professor Bitoki and other stalwarts in hysteroscopy have explained, put the scissor inside under vision, reach up to the internal os, and then open the scissor and withdraw. So this causes a dilatation of the cervix as you withdraw the scissor, and then you find that you are able to go inside the uterine cavity very easily. Yes, there will be instances when even this maneuver is not possible, and those we will probably take at some other time. Incidentally, I had posted a image or this thing in endogyne quiz, training quiz number 16. Sadly, that has got deleted, and which this particular aspect was covered as to how to enter even when this technique literally fails. So saline does show the way, but you need to have other tricks up your sleeve as well. Then comes the question of pressure dilatation, hysteromat, pressure bag versus gravity. So someone has posted in the group about the use of gravity. Personally, let me tell you that I have zero experience about the use of gravity. Sorry about that. So I do not have any experience regards the use of gravity at all. But what I can say is I would imagine that it would be rather difficult to do a large or a long operative case using gravity alone. But if this is possible, then that's great. I mean, you can continue to use it. It would be one of the safest ways to distend the uterus. But personally, I don't think gravity will be sufficient. So then comes the use of hysteromat versus pressure bag. And we are using both hysteromat as well as pressure bag for a variety of cases. Once you know how to use the hysteromat and also to use the pressure bag, I can say that both are extremely good. Of course, the hysteromat scores over the pressure bag because it is much more calibrated and graded, but that is not to say that the pressure bag cannot be used at all. It can be used in a good majority of cases to give the distension. So my choice of distension will be to use a pressure bag at all times. I'm sorry. Yeah, so then we go to the next point of discussion. My recommendation will be to use a hysteromat at most of the times and keep the intrauterine pressure slightly at about so you can keep it at anywhere between 120 to 150 millimeters of mercury, or for a difficult entry you may increase the pressure to a little beyond this, and once you go inside you reduce the pressure again to about 120 so that there is no excessive fluid overload. Then the use of evening primrose oil, I am really not sure about this. I have zero experience in using primrose oil. If someone can share their experiences about how it helps in hysteroscopy, that would be fantastic. As regards timing of surgery, I would prefer the post-menstrual timing always, because there are less of artifacts that are seen inside the uterine cavity. Also, if you post the patient premenstrually, then the problem is that a lot of polyps may be seen, or they're actually small polyps may be hidden under the endometrium, so we are not really able to see them. But as far as entry inside the uterine cavity is concerned, premenstrual or postmenstrual, I don't really know whether it makes a difference. Then comes filling the bladder. So filling the bladder does straighten somewhat the axis of the uterus. So one could imagine that if it is a acutely antiverted uterus, then filling up the bladder may just, so if this is the bladder, then filling up the bladder may just cause a pressure on the uterus and it may straighten out the axis. But frankly, how much to fill and how long to fill is the question. So this is at least not a technique that I use or I am comfortable with. Probably those of you who are doing more of IVF are using this technique for easy entry using the ET catheter, and that may be useful. But under anesthesia or for hysteroscopy, I'm really not using this technique too much. Then, so what happens if there is an acutely antiverted, acutely retroverted or ventrofixed uterus? That was the next question. And regardless of how the uterus is, if you are able to learn the approach of see and enter, So there is a specific way to do this. Maybe we will have a lecture on this sometimes, or we will discuss this in the upcoming webinar on hysteroscopy, which we are planning in a few months down the line. And in my opinion, this technique is the most important technique to learn if you are going to consistently do safe hysteroscopies for a long period of time. Once you understand the see and enter technique, then regardless of how curved or how crooked the cervical canal is, you will still be able to negotiate. So you don't, the positioning and the changing and the hand movements literally depend upon what you see on the screen. It is not fixed that for an antiverted uterus you have to do this hand movement, for a retroverted you have to do this hand movement, and for a ventrofixed uterus particularly, the see and enter approach is excellent, because in a ventrofixed uterus you cannot hold the anterior lip of cervix. It is lost behind the pubic symphysis. So see and enter is the only way by which you can go inside. Then coming to the next question, difficulty in inserting the rectoscope. I perfectly agree, this is a genuine problem, but then it depends on which rectoscope you are using. Earlier I used to use the 26 French rectoscope. Remember that the 26 French rectoscope goes with the telescope, which is the 4mm telescope. Now this requires a dilatation of Hagar 10 or 10.5. As compared to that, what we have now is a 22 French resectoscope. The 22 French resectoscopes works with a 2.9 mm telescope, and this requires a dilatation of 8 or 8.5. So between the two, it may not seem like a big deal, it is just 2 dilators more, but when you have actual patients who are having infertility and cervical stenosis, this becomes a very big deal. It is quite easy to dilate up to number 8, but it is extremely difficult to dilate up to number 10. So for those of you who are using a 26 French, I would recommend moving to a 22 French as soon as possible. Then of course there is the 18 French and the 15 French which is available, and this is for office use. So needless to say, it does not require, no dilatation is required. So this just goes inside the uterine cavity without any dilatation, and if you have the resources, it would be good to purchase this as well, so you don't have to worry about anything or any entry in the future, no matter how stenosed the os may be. Then we come to over dilatation and leakage. Yes, this is a problem. So remember that leakage may be there if you over dilate the cervix, but this leakage can be controlled. So in case by mistake you have over dilated the cervix, at least what I do in my practice is that if this is the cervix and this is the os, and there is a lot of leakage which is coming out from here, of course you have held it with the vulsellum, we apply one more vulsellum over here. So the vulsellum goes like this over the anterior lip, and it goes over the posterior lip, and it kind of pulls draws the two lips together close to each other and reduces the effective diameter of the external os. So this simple technique manages the over dilatation and leakage problem in a vast majority of cases. Of course, if you feel that in your practice misoprostol is the culprit, then you can stop using misoprostol, but I have not had this problem because of misoprostol in a majority of cases. Again, this problem will be encountered if you have a patient who has got a very patulous cervix because of multiple vaginal deliveries. In that case, maybe this is the technique that you may have to resort to. Coming to our last opinion, which is using the dilator and the Foley's catheter. So last someone has said, I have no experience in using a Foley's catheter to help me gain entry in cases of cervical stenosis, because I really don't know how the catheter will negotiate inside if there is a genuine cervical stenosis. But the important thing to remember is the dilator. So is the dilator completely outdated from the trolley? I think not. Many a times when nothing else works, you can use the hysteroscope, take a look inside the uterine cavity. You are not able to dilate, but you can see that the crypts are converging at a particular point. Once these crypts are converging at a particular point, try to note where that point is in the cervical canal. So is the point over here? Is the point over here? Is the point over here? And correspondingly, so now you know if the point is over here, you know that the dilator that you are going to insert inside, you have to angulate the dilator more towards the anterior wall. So when you actually insert the dilator inside, and if the cervix is like this, then instead of just pushing the dilator like this, you may probably try and angulate the dilator in such a way that you try to push it in like this. And this simple technique may help you to negotiate the internal os very well. So sometimes dilatation does have a role. If you try to force a 2.9 millimeter hysteroscope through an internal os which is badly stenosed without doing any other corrective measures, then the telescope might end up breaking, and definitely we don't want that. So there is a role of dilators on the trolley. It is not to be removed completely, and when everything else fails, you can try with a dilator as well. Remember, however, that like some people have suggested in the group, I really do not go with a dilator which is very thin. So I don't use a 3 or a 4 number Hagas dilator, because such a thin dilator has a propensity of causing false passage more. In my opinion, it does not go inside the correct canal, but it is sharp enough to create a canal of its own, and therefore it causes a false passage. So I do not start with anything less than 5 or 5.5, and I find that in cases where everything else fails, you can take a note of where the opening is and pass the dilator accordingly. So at least this is what I do in my practice. So I think we've dealt with most of the queries that were posted. So as a take home, what I would say is learn the correct technique. This is the most important part. The vaginoscopy hysteroscopy technique, or you can call it's called the no touch technique, or it is the see and enter approach. This is the most important part of being able to enter. In my case, I would recommend the use of Misoprostol, but it is up to you in your practice what you want to do. If you are not able to enter with the regular technique, hold the cervix and pull the anterior lip. That might straighten the cervical canal. The use of lubrication like a simple jelly, a simple xylocaine gel or a jelly that we use, this may help the tip of the telescope to slide inside slightly. Using a narrow telescope like a 2.9 or a 1.9 mm telescope is essential for being able to perform hysteroscopy safely. And the last that I would say simply is practice, and there is really no option for that. So keep on trying some of these techniques, and I'm sure that this problem of difficult entry will be solved quite soon. Now before we conclude, this is one last slide which I'd like to show you. This was a video that I had posted in the group, but unfortunately it got deleted. And you can see over here, this is a lady who has got, one denotes RPOCs. So this is products of conception. This is blood actually, not RPOCs. This is blood which has been trapped. This 2 is the recurrent products of conception which have blocked the way, and you can see where I have marked number 3, you can see this area is got a discontinuity in the endometrial lining. Now here the only problem that happens is with such a discontinuous endometrium, it goes here and then it goes from here, there is nothing over here. Now the only problem that happens is when you try to negotiate this and the hysteroscope has reached up to here, it is rather difficult to understand what should be the trajectory of cutting. Here opening, inserting, thrusting the scissors and opening it is not going to help, because there is no canal here. You have to literally make a canal, and this is a point where experience will really help you, because what will happen is if the starting trajectory of your dissection is wrong, if this is the correct trajectory, but if your trajectory is like this, or if your trajectory is like this, even by a few millimeters, if you start wrong, then you are bound to end up at the wrong place and cause a perforation, no matter how good you are. So these are some of the few things that probably we'll deal with in some subsequent lectures on YouTube, or maybe as a sit-down discussion when we have our next webinar on hysteroscopy. But I thank all those of you who have contributed to this discussion, and for those of you who have still not yet joined, I would invite you to subscribe to our YouTube channel and also to visit our website www.endogynetraining.com, and you will find the link there on the home page to join the group. So you can also join the group and take part in our daily discussions. So that's it for now. Thank you very much, and if there are further doubts, then feel free to post them in the group and we will answer. Also, I would like to thank those of you who have given their time to answer others' queries, because this creates a mutually helping environment and all of us can grow together, learning from each other's experiences as well as learning from each other's mistakes. So thank you very much. I hope you enjoyed your weekend.